The current teaching of delivering an initial shock for a shockable arrest rhythm and then performing 2 minutes of CPR prior to increasing the energy and shocking again if the shockable rhythm still exists is really based on predominantly out-of-hospital arrest data. This patient population typically has a longer time to CPR initiation and etiologies of arrest that are different from the hospital patients. The rationale for this 2 minutes of CPR between shocks comes really from the idea that these hearts have been down for an extended period of time and need to be perfused or primed in order to respond to the defibrillation, and thus they need 2 minutes of CPR between shocks. Individual patients in the hospital might require higher energy defibrillation to terminate arrhythmias, and achieving that threshold in a stepwise approach as soon as possible minimizes the potential time to return of circulation. Thus, in hospitalized patients where priming the pump has less physiologic rationale, the initial shock for a shockable arrest should be followed immediately, without pause, by up to 2 more stacked shocks of increasing energy levels until return of circulation occurs or the patient changes into a non-shockable alloc rhythm. The timing of this sequence is important to minimize the amount of time between shocks. If the patient persists in a shockable arrest following the initial 3 stacked shocks, 2 minutes of CPR should be started at that point, and subsequent shocks after the 2-minute pause rhythm checks should remain at the maximum energy level. The stacked series of shocks should only be utilized on the initial entry into a shockable rhythm. This change addresses the difference in arrest physiology between closely monitored hospital arrests and out-of-hospital arrest etiologies and response times. Looks like we have a rhythm back. Rhythm check and a pulse check. Looks like we're back in sinus. And we've got a pulse. Let's drop that 360 shock.